Dr. Linda of the Vascular Birthmarks Foundation, live today from New York with Dr. Robert Rosen, the Lenox Hill Hospital VBF expert and interventional radiologist, not just extremity expert. I always qualify this, but abdominal, and I say
Everything
from
the neck down.
that's what I put on the post, everything from the neck down. So we will be taking your questions for 60 minutes. I'm just gonna make sure it's loaded on my phone here. I'm not seeing it, so I can see some people are popping on. There we are. All right. Oh, geez, there's already a comment. Okay, let's see. Oh, thank you. Hi, Thea, Jackie, and everyone else. Hello from Dr. Rosen and myself. We can take your questions. Hi, Scott. So any questions, and we've just been talking about some new procedures coming out, the electrosclerotherapy, and about you taking a course or participating in some kind of a course and bringing it to the U.S. It seems to be offering a lot of promise. We're hearing.
The initial reports are very good.
For it, now I know we just spoke about it for AVMs. What about VMs? Venous.
Actually, probably works better for
That's
VMs.
what I was thinking.
Yeah, slow flow is always easier.
Yeah.
For direct energy delivery. Yeah.
Less blood, easier to manage, right? That makes sense. Okay, so hi Deb, hi everybody. We can take your questions, so as soon as you submit them, I will read them to Dr. Rosen and he'll be able to answer, but as we were just talking, Dr. Coletti's from Italy's been doing this a type of electrosclerotherapy, which isn't exactly new, but
it was used for tumors, actually goes back 20 or 30 years.
Right.
Now the technology is being adapted to use for vascular malformations.
Right, and Dr. Coletti's using it with bleomycin and using it as a delivery agent, and he's having phenomenal results with the head and neck AVM. So we're going to have an all AVM clinic and an all AVM lecture day. So I think that's going to be the best, where you have all the patients and then you have all the lectures. To me, that makes things the best. Hi, Kasol Batul. You remember? No, Kasol. You remember her. Hi, Kasol. How are you? We hope you're doing great. We haven't seen you in probably 10 years here. I don't know when the last time. If I keep going BC, before COVID, and it used to be before Christ. Now it's before COVID, and so I always say before 2019, because then we just were shut down for so long. So we can take, we were just talking about the new electrosclerotherapy that Dr. Rosen will be participating in and hoping the AVM Center is perfect for this, when you think about it.
Well, we're in the process of trying to get the device FDA compliant in the United States. So it's a complex issue to get new devices approved. And so it's kind of the beginning of the process.
So I just have to find out, because I know Dr. Coletti is the KOL for the device that he's using in Italy. So they're funding his research. So that device has only been approved in Europe, is that right? And so
that's right.
Here
it's
it has
not available. Yeah, I mean, there are devices that have been used for tumor treatment that I think people will try to adapt it, but the actual dedicated device for this is not available at the moment.
The other thing that we just found out the other day is the state of Tennessee has approved, if there are any international physicians that offer a unique skill set, that they can actually practice in Tennessee now with a sponsoring hospital. So we're trying to see if something like that can happen. And I'm just wondering, if we can get something like that. I mean, it seems crazy that you have to go through the FDA, which is a nightmare.
Yeah, well, easier with devices than with drugs.
So then maybe in the next year.
Yeah, I wouldn't be surprised. There will be a clinical trials, obviously. So that still has yet to happen.
I'd really like VBF to be involved. So if you need anything from us with patients. Oh, here we go. Hi, Lauren. Lauren McCabe has a 9-month-old daughter who recently had an ultrasound and they found a persistent embryonic vein. Our IR recommended an outpatient procedure where she's going to close it off around 2 years old. Any insight? She has a birthmark on her right abdomen all the way down to the foot. Overgrowth of RLE.
Right lower extremity.
Yeah.
Well, it's kind of a typical KT presentation, is the port wine stain, overgrowth, and anomalous veins. And that lateral anomalous vein, especially along the thigh, is a very common location. And of course, you have to make sure that the deep system is present and adequate to carry the venous drainage, which 90% of the time it is, but you want to know it's not one of the small percent that have hypoplastic or absent deep veins, in which case you don't want to close off that.
Can you do that with ultrasound?
Yeah, you can do it with ultrasound. And
so that's good.
Yeah, and also at the beginning of one of these procedures where you're going to close off an abnormal vein, you usually do a pre-op venogram or venogram while they're asleep on the table and verify what the status of the deep veins is.
So
That's
we
important.
we also have 3 new groups from Facebook joining us, which are May-Thurner syndrome. So
Mhm.
you know that's
Right.
a little bit of a crossover. We have patients that have both, and they just really have no organization. So they've kind of latched on to VBF. So, I mean, we have there's one patient, Lori Furstenberg's daughter, and I know she likes me to advocate for her and get new information about the treatments, and they're talking about sirolimus now for some of these patients.
For May-Thurner?
Yeah. Well, hers is KTS,
Yeah.
but she's got that right iliac artery with the.
Yeah, I would be a little surprised if
If it
pharmacotherapy would be effective for true May-Thurner. It's actually kind of an overdose syndrome because many people have an impression of the artery on top of the vein. So just the radiologic finding isn't always correlating one-to-one with
That's
pathology.
That's very interesting. So,
And there's been a lot of stenting done, venous stenting, which has a significant downside. So I think it's important that stents aren't overused, especially in children, because it's a long-term issue.
well, she'll be happy to hear this because she's
Yeah.
been postponing it.
Yeah, you need to measure pressures. You need to see if it's a significant pressure gradient across the lesion, because just seeing a linear defect is not necessarily pathologic.
So Thea Sanchez says, my daughter has a very large port wine stain on her face. Would this procedure be something for her? She's 17. Our darker skin pigment seems to be an issue for doctors, and the symmetry on her face is causing insecurity.
Yeah, well, again, I'm not a head and neck or facial vascular malformation person, but one of the reasons pigment matters is for laser treatment, and obviously her external beam laser can be effective, but what you really need to see, and what this electrosclero is claiming at least, is that when used as a invasive technique where you actually put probes into the lesion below the surface. So it really depends on whether it's just a skin birthmark or whether it's actually the outside manifestation of a deeper venous lesion.
That's very interesting. She said there's some dysymmetry, so she may have some overgrowth
So there probably
going
is
on.
some soft tissue
Right,
overgrowth going on under
right.
the surface.
And by the way, we have the conference the weekend of October 6th, 7th, and 8th, the VBF conference here in New York City. And Dr. Rosen will be there along with Dr. Geronimus and our whole team of doctors. Dr. Coletti will be doing free ultrasound, Dr. Darrow free dental, and this year we're offering free glaucoma screenings for the babies. So I'm really excited about offering these new services. Dorothy McCabe wants to know, what's harder to treat, a venous or a lymphatic malformation?
Lymphatic almost always is more difficult. And there's different kinds of lymphatic malformations. There's so-called macrocystic, where you have a large fluid collection of lymphatic fluid, and those are fairly easy because you drain them and sclerose them, and they usually respond very well. The more common pattern is microcystic, where you have lots of tiny cysts, and they can be very difficult to manage. Venous are more straightforward usually.
I wonder if the electrosclerotherapy will be beneficial.
Remains to be seen. But, yeah.
Maybe promising,
Yeah.
because, I mean, they've gone after some things smaller than microcystic lesions. So let's hope and pray, right? Okay, so we're taking your questions. People are registering that are hearing us speak for the conference right now. It's popping up, so Kristen just registered. Thank you, Kristen. It's a good thing. Come and hear Dr. And you can be on the team and see Dr. Rosen. Okay, so what about sirolimus? Do you want to address that? Because a lot of the KTS patients and the venous malformation patients with extremities, especially the older adults, are being told.
Yeah, and it's anybody that deals with this knows this is a controversial area.
Mm-hmm.
And there are some people who are non-believers in the current state of drug treatment, including sirolimus and alpelisib and drugs like that, and some people that are skeptical about it. And I am somewhat skeptical. I think there are situations where there's intractable pain or lymphatic leakage or hematologic issues where it clearly can be beneficial, but an adult with a structural problem like KT, I'm not personally convinced that the drug therapy has much of a role there.
Well,
And
especially
there's been series in the literature, multi-center series, most of them retrospective, but the results statistically haven't been all that impressive, even though there are people that claim.
yeah, and not only that, people who were on it during COVID and couldn't get access to it, like completely reanimated.
Well, that's the problem is even if the drug works, when you stop it, you kind of go back to baseline in most series. And there are side effects, some of which we know about and some of which remain to be seen because it's a fairly new application of these drugs. If the drug has been around for a while, using it for this indication is fairly new. So we've been burned in the past sometimes with drugs that had extreme claims and turned out to have issues long term.
Well, we had alpha interferon that we
example.
went through, steroids too,
Yeah.
the overuse of steroids,
Yeah.
vincristine, another chemotherapy agent. And even now, though, beta blockers are like the gold standard for hemangiomas, but there's a lot of problems with the babies with reflux and diarrhea and
And with sirolimus, and alpelisib, there's GI issues, there's mouth ulcers, there's flu-ish kind of symptoms, and some other things that are less common that may be more serious. So I'm cautious. I mean, we use it basically when nothing else has worked well, and some people use it right off the bat as the first approach, and I'm a little skeptical about that.
And I think what you're saying, which makes a lot of sense, if it's a mechanical, structural thing that can be removed or managed and maintained, why go on a systemic drug with so many downsides to it that if you go off for any reason, it's all going to come back?
Yeah, so it's controversial, and my opinion isn't shared by some other people in some major centers where they use it very freely, and they claim great results. And in my experience, there are cases where it's very beneficial, and many more cases where I don't see you're getting the side effects without dramatic benefit.
Not that sclerotherapy and embolization doesn't have some side effects, but
Clearly nobody has a magic.
Right.
Nobody has a
but
magic
it's still the
wand
gold
where you do it.
standard. It's still the gold standard, correct?
Which sclerotherapy and
And for
for
extremity
suitable
reasons.
for suitable anatomy. I mean,
Yeah.
you need, and I think the drugs may have a role when there is no direct intervention that mechanically would improve things, closing off a very big abnormal vein or something that might be helped with sclerotherapy or embolization. But every case in this field is obviously very individual, not two are alike.
I don't know if you heard about this, but I have collected 7 cases, and some of them are quite old, and most of them were patients that you had in the past, and they've developed breast cancer, and they're saying they carry this mutation for malformations and breast cancer. Do you know anything about that?
Yeah, I mean, there are syndromes that appear to be the same as, say, a typical KT, which actually predispose Cowden syndromes like that, that have a genetic basis that, not genetic in the sense that they're transmitted in families, but that are genetic mutations. And yeah, they can predispose, and those people need monitoring for thyroid tumors, breast tumors, other kinds of tumors, colon cancers.
You know, I'm just wondering now too, and I'm saying this out loud, but I think this is going to get worse with something like sirolimus because it's a chemotherapy agent which is meant to suppress tumor growth or some kind of angiogenic activity. But then if you go off of it or if you get sick or something else happens, who knows what else it can be stimulating in your body.
No, it's all theoretical, so I wouldn't even comment on that. But yeah, it's a fairly small segment of the vascular anomaly population that have these genetic abnormalities, and there are now labs that are much more sophisticated than they were even 2 or 3 years ago in terms of doing genetic analysis and seeing who has what trait.
We had a couple moms write to me who have teenagers, 3 moms that have teenagers with FABA. They've been diagnosed with FABA. Is there anything new for them? Because one of them is actually talking amputation just because of the chronic pain.
Yeah, well, FABA is another one of these very controversial areas, and they're certainly not straightforward to treat like a regular intramuscular venous malformation, although they could mimic them, and there are certain radiologic findings that would lead you to the diagnosis, such as fat in an MRI was kind of characteristic of FABA, and disproportionate pain compared to a typical malformation. You know, there are kids, it's usually in kids, that you can't even touch the extremity where the malformation is, which is very atypical for a regular vascular malformation. And treatment has been less than dramatically successful. So they were talking about using cryotherapy at one point and sclerotherapy, and currently the most effective treatment, if it's technically possible, is actually surgical removal of the lesion. That seems to be the best treatment currently available for these.
Oh, okay, so yeah, it's rrosen2 at northwell.edu, that's correct, right? That's
Yes.
the new one, yes,
Mhm.
that's a correct one, Scott, thank you for posting that. Another question on the FABA is, because it's fat,
Well, it's not fat.
Well,
There's fat
a
in the
fib-
midst of a
yeah.
complex malformation.
right, it's, well, that's why it's fibro, like, or
Fibroadipose vascular anomaly. So there are
fi-
veins, there are
fibrous
fibrous tissue, there's
fibrous
lymphatic
and
tissue,
some fat.
and nerves, which is why they're so.
I just, you know, when
Sensitive.
you say that you can touch these kids, you know they're not making it up. When
Oh,
you
yeah.
touch them,
Mhm.
and it's,
No,
then
it's dramatic. Yeah.
that's neurological then, we're talking really,
Well, there is abnormal nerve tissue mixed in with the other
Okay.
tissues, so
But then with
nobody
these-
really understands the mechanism of why they're so much more symptomatic than a typical venous malformation, but they are.
and what about compression? There's been a lot of moms that have the babies that are born with the, you know, obvious KTS at
Mhm.
birth, and they're being told not to put them into compression garments until they're in puberty.
Again, it seems like everything we talk about is controversial.
I
But,
know.
but that is I guess that's the more interesting things to talk about. I think when compression was the only treatment available, and in the classic surgical literature, that was kind of what was advocated was compression started early and use it day and night as much as you could tolerate. There are some people that feel much better with compression, and it's probably helpful for them. There are people that can't tolerate compression, and they're really suffering if somebody forces them to use it. And I don't personally believe that it makes you feel worse, that it's that beneficial in the long run. So our goal when we treat these patients is to free them from needing compression, because it's such an interference with normal
That's
life.
very interesting. Then what about hydrotherapy, swimming, water therapy?
No, it's good exercise, and it's the best exercise in terms of low impact, and yeah, we encourage that. It's probably the best
What about
low impact.
manual, like almost like lymphatic massage therapy? Is that detrimental or helpful?
No, it's not. It's certainly not detrimental. If you have a significant lymphatic component, it can be dramatically effective. Unfortunately, there's a shortage of people around with the expertise of doing it properly. For KT, for typical venous dominant KT, I'm not sure. I don't think it's particularly effective because it's so transient. If the
Right.
limb is dependent, it fills with blood. If it's elevated, it empties, and just manual decompression is really not going to be effective there.
Thank you. Dorothy wants to know, when is an MRI important to use over risks of sedation in an infant with an extremity lesion?
MRI is clearly the best diagnostic study we have. Ultrasound is easy and it's quick and in the office and it's non-invasive. It doesn't give you nearly as much information as MRI. So MRI is kind of the keystone of imaging. You know, the question is, when do you do it? And if it's something that requires anesthesia in a small child, is it worthwhile? And really what it comes down to is, are you going to treat depending on what it shows you?
Right.
If you have no intention of treating for a couple of years, there's no point in taking, going through the whole general anesthesia thing in a 3 or 4-year-old if you're not going to treat
Right,
based
and,
on those findings.
and the new anesthesia study just says, try not to have more than 3 under age 3. But your treatments aren't like port wine where they go every 4 weeks.
No.
And they're under general anesthesia. So usually the imaging is only done once, right?
Yeah, you don't need to get constant MRIs. You know, we usually base it on just the clinical response to treatment. If somebody's doing well after treatment, you don't need to get a new MRI to document. Because there's also a very poor correlation, honestly, between MRI findings and clinical response. We have people that you look at the post-procedure MRI and it's not dramatically different, but the pain has largely gone away. Everybody's got a theory about why there's such a poor correlation. I personally think the sclerotherapy, even when it doesn't obliterate the abnormal tissue, it makes much stiffer membranes involved in the malformation such that it doesn't distend with blood when the limb is dependent.
Right, and then it's not compressing on the nerves, which cause the pain.
Or just the fluid building up in the tissue.
Or
causing
the
pain.
surrounding, that makes sense, it's very
Yeah.
logical. So, she said her 9-month-old is experiencing no pain, is happy and healthy otherwise, besides having the overgrowth and the lymphatic malformation. Would you recommend it? I'm leaning towards holding off for sirolimus.
Controversial. I think if there are fairly major changes going on in terms of the port wine stain and the overgrowth, that's one situation where I could actually see a justification because you're interfering with the dynamic process where it's actually the tissue is growing. It's not like a 40-year-old that has
Right.
a fixed malformation.
Right.
So I think I would encourage them to go to a big center that has a lot of experience because anybody can write the prescription, but you really need the right monitoring and meet the right criteria.
Do you have any babies on it?
I usually refer them for the drug treatment
Right,
to
yeah.
somebody in hematology or oncology.
Yeah.
As I said, anybody could write the prescription, but
Right.
it has to be part of an overall treatment
Right,
program.
a multidisciplinary plan.
Correct. Yeah.
Sherry wants to know, I know a port wine stain on the leg could be KTS, but I'm curious what a percentage estimate would be that it could be not KTS, just a port wine. My granddaughter is 8 months old with a port wine on half of her back, which does slightly go across the midline and goes onto her thigh and down to her foot. She has no other symptoms or signs of overgrowth.
I have to say, if it's that extensive, the odds are there's something going on under the surface. It's probably just not a simple port wine stain. So that is something that should be followed and probably imaged at some point.
So you can pass that on to Mom, and you're a good grandma for writing that in for your granddaughter asking it, because there is a lot of misinformation out there.
Oh, yeah.
And a lot of people could say, oh, that's just a port wine, you don't need to do anything about it. Or they could see a port wine and say, oh, that's an AVM when it's just a port wine.
Yeah.
So that's why an accurate diagnosis is like in our mission statement. You know, you don't begin treatment unless you have an accurate diagnosis.
Well, you wouldn't believe how many patients we see at their first visit. They've been followed by different doctors for 5 years, 10 years, 15 years, and you mentioned KT and they've never heard of it. And they could be an absolute textbook case. So it's still not, people that have a family member that's affected or people in the field. It's every day, KT is the commonest vascular anomaly we see by far. But it's still rare. So the average
Right.
pediatrician or general practitioner is not going to have seen much of it.
Lauren says that they are in the city. Oh, you're right here in New York, at New York Presbyterian Columbia. I don't know about their vascular anomalies team.
They
Are
have
you
a good program.
familiar with
Yeah.
It's pretty
Yeah.
good.
Mm.
Who's their IR there, do you know?
I know Dr. Sussman
Okay.
runs the section. I'm not sure who's actually doing most of the cases.
Okay, well, it's good to know. I should
Mm-hmm.
look into them. I didn't even know that they had a vascular anomaly. So maybe I know like a derm or something out of it, but I never didn't realize that.
No,
So
they're very good.
that's good.
Mm-hmm.
And then there was another question that I missed. Where was it? Oh, it was another one that was slightly similar, saying if there is overgrowth at birth, will it continue to get larger, or will that percent of discrepancy be the same?
Unfortunately, if it's present at birth and easily seen, it tends to be one that's going to become disproportionately larger. It's not like it's going to grow at the fixed rate that the other body tissues grow.
Okay, it is.
So
Okay.
that's why there is more of a discussion in those cases about the use of pharmacologic agents.
So because in the old days, I know in the old days, they used to say, well, you know, it's not gonna be a giant leg, cause it's not a giant leg at birth, but you're saying.
Well, if it's a visible discrepancy
Yeah.
at birth, especially with a port wine stain, the odds are that it's gonna become a significant issue as the child grows.
Yeah, and by discrepancy, like sometimes it's marginal. I call them the 5%ers.
Mhm.
You can see it's bigger, but just marginally.
Well, it's also important to decide or to distinguish girth versus length.
Right.
In other words, a length discrepancy of greater than 2 centimeters typically is what's quoted, may need to be followed, and you might initially just need a lift in the shoe to even out the to avoid pelvic tilt and secondary scoliosis, things like that. And if it's significantly over 2 centimeters, they often will recommend epiphysiodesis, closing which is not a big
The growth
operation, but
plate.
close the growth plate once they calculate what your final height will be. So
That's
you end up even.
That's something too that I've heard Dr. Coletti talk about with the jaw overgrowth too, is going in and
Yeah.
keeping that growth plate from continuing to overgrow. And I suppose then, when do they remove that? Like 1920, or do they?
Usually, well, if you close the growth plate, usually just leave that for the duration of adolescence, basically when growth stops.
Right.
So
it is when the growth stops.
mhm.
So we're caught up, but thank you all for your questions. I see a bunch of you are on. So Dr. Rosen is here to take your questions again. Extremity. A question that I have is this very rare, I believe they call it a pericytoma hemangioma, and it was in a baby's abdomen, and the baby passed away. Have you ever treated one of those, or?
Well, there's a bunch of aggressive kind of the tumors, actually, not malignant
Yeah.
tumors, but the effect is just as bad as some malignant tumors that can cause hematologic abnormalities and can grow dramatically. And that's kind of a whole different category from
So they're not
regular
ours,
vascular
like,
malformations.
okay, so they are different. So
Yeah.
they're more like KHE, more like a,
The effects can be,
like,
yeah.
like a borderline malignant.
Yeah, I mean, the effects can be as
Oh.
dramatic as a tumor.
One of your favorite patients, she loves you, Emma Albert. Hi, Dr. Rosen and Dr. Linda. I should have asked this the other day, but I was curious to hear your thoughts on ligation, compartmentalization, and phlebectomy to decrease the volume of a venous malformation. I've had some friends in Buffalo do this alongside sclerotherapy and would love to hear your thoughts.
I think not so much ligation, but anything you could close by ligation, you could probably close from the inside as well without an actual surgical procedure with embolization, whether it's coils or glue or something like that. But you need the appropriate anatomy. So if you have large abnormal veins that have no proper valves in them, such that they transmit pressure down the leg, especially when you're standing, those are suitable for closing anomalous veins. If you don't have that anatomy, it's not really going to be applicable.
So I don't know if that would be applicable to Emma, but you know, these young people talk to each other, and
Of course.
they don't understand that even if the exterior of the leg looks similar, that the anatomy can be completely different, subcutaneous, right?
It's cliche to say that no two are alike, but this happens to be one medical
Right.
condition that it's hard to find two that are exactly alike. You could say there are certain patterns where you have a lateral vein that's abnormal. You could have other kinds of architectural abnormalities of the venous system, but very, very few are exactly fitting the same pattern.
When they are absent of that deep venous system, is there a procedure that they should absolutely avoid that will make
Closure of even if the vein is abnormal and it's your only venous drainage, you don't want to close that because then you have intractable swelling.
So that's an
And you can't reverse
example
that.
where you don't want that ligation.
Yeah, and that's why either with ultrasound or a venogram or some combination of those or MRI, you need to know what the status of the deep system is.
I hope that explains that, Emma. And again, like he said, no two are alike. Missy wants to know, I'm not sure how anyone would answer this, but how many treatments would you start to see improvement on a face port wine stain?
I would actually refer that to the people that treat those, Dr. Geronimo.
Dr.
or somebody
Geronimo.
along those lines.
I can tell you from 29 years of observing that no two are alike, like you already said. I've seen, well, I can tell you, the babies, I had one sent to me today for a baby that he's been treating weekly, and by 3 months, the baby's completely cleared.
Yeah, I was going to say that the response in the face is much better with laser than elsewhere in the body.
Oh,
kind of the typical saying is the further away you get from the face, the more difficult it is to have a beneficial effect. For
Still
example,
the
on
same.
the leg or the abdomen, don't
Yep.
respond nearly as dramatically.
Hands, we have
Right.
patients that have the.
Yeah.
Lauren wants to know, any thoughts on alpelisib, the newer medication that came out for 2 years and older came out for 2 years and older for PROS patients, babies, I guess.
Yeah, well, it's the first drug specifically approved for this application, and again, it kind of depends on which literature you believe. There are some people that are using it a great deal and claiming dramatic results, and some people are saying, and some of the series in literature are showing not so impressive results. So I think the jury is still out. If it's something that doesn't have other good options, I think it's a reasonable thing to do with all the caveats we talked about before, putting young people on fairly powerful drugs
Well, like,
for an indeterminate period of
yeah,
time.
when any of these drugs come out, it's just a wait and see.
Yeah,
Yeah.
and everybody in this field has been through at least 5 miracle treatments that 5 years later nobody was talking about anymore, or that there were adverse things.
Right,
So I'm not
right.
trying to throw cold water on it, but
No,
I think you need
You
some
want
caution.
cautious optimism.
Yeah,
Cautious
exactly.
optimism.
Yeah.
So Sherry says, back to my 8-month-old granddaughter, if it is possible, because she said it was quite extensive on the
Mhm.
body, that she will present with KTS, what could be done now? And I was just gonna say she could come to our October clinic and get an ultrasound.
Yeah, although probably if it's that extensive, MRI would be a good thing to do, because
Yeah.
you're not going to be able to evaluate everything with an ultrasound.
Right, but we don't need it, she's 8 months old, they can wait, right, until she's over a
Yeah,
year.
you're probably, and again, it depends on how prominent the findings are, but some people would do an MRI early, because if you
Okay.
think somebody may be a candidate for drug treatment, probably the earlier you start, although Pelcid, it's kind of a 2-year cutoff right now.
Oh, it is?
Yeah.
Well, Sherry, Scott posted Dr. Rosen's email, so you can send him some pictures and he can give you an opinion.
Sure.
If you would like. Another one, she said her granddaughter has a lymphatic malformation in her axillary area near breast tissue. She's 9 months old. When would you treat her?
Well, if you're dealing with something that's actually going to affect the breast tissue itself, you try to be very conservative, because you don't want to inhibit. There's a breast bud there that's the origin of the normal breast development. If it's in the axilla, so it's actually away from the breast tissue itself, you could treat it with sclerotherapy or surgical resection, depending on how localized and accessible it is. But again, you'd know that from an MRI.
I was
That would be the first step.
I was wondering if the alpelisib is working, or sirolimus, either one, and you see a baby, a 1-year-old, a 2-year-old, and you're like, okay, this one's a candidate. If you get some shrinkage, then can you go in and treat, and will it be more effective? Like, use this to kind of head it
There
off.
are reports of converting something to
Yeah.
something that's more directly treatable with either interventional treatments or surgical treatment. So yeah, that's.
And then the hope would be then they wouldn't have to be on the drug for life.
Yeah, although it's a bit of a contradiction there, because if you have something that's that diffuse that you're going to start treating very early, it's usually too diffuse to be appropriate for surgical resection. There are
Right.
debulking
But
surgeries.
I wasn't
surgeries that are
thinking,
done
I wasn't thinking of surgery, I was
in a
thinking of,
localized lesion.
yeah,
or-
to sclerose or embolize, like, if it has some shrinkage, like a
Yeah.
50%.
Well,
Then does it
most
need-
of these patients will require combined treatment.
Oh, they will,
Yeah,
anyways.
yeah.
Okay, so they won't just stay on the drug, there'll be a point where,
Hopefully.
okay,
Hopefully.
that's good to know. Okay, yeah, Dick that she wants to download that brochure. Yes, you can, Dr. Geronimus, Missy, is the only one that I know that's treating Port Weinstein's weekly, although we hope it becomes more norm, because starting at 2, 3, 4 weeks and doing it, and they're done at 3 months, family gets on with their normal life. And I love Dr. Geronimus's theory that while it's still has the purpura and is still kind of cooling down. You go after it again, and he keeps sending me these unbelievable, and of course, the claims are that the hemoglobin is more receptive to the laser in infants, and that the area is much smaller. You know, a whole cheek of the baby's face is only this big when they're a month old versus an adult size. So that's why we are
I think it's
advocating.
reasonable, and that's one of the reasons we're differentiating dynamic lesions versus static anatomic problems.
Yep.
You know, Port-Line stain in a baby is something that's actually a dynamic process going on.
Yep, and Missy, my email is vbfpresident@gmail.com, and I can talk to you about Dr. Geronimus's weekly laser program. It's a study that he's doing right now, and I just actually referred a woman from Ireland who's staying with family in Boston and driving over weekly to get it, because in Ireland they don't even start till age 3. So she's going to be done in a couple months and go home. Hi Raya Chandola, and Alana's on. Hi Alana Dolce, another one of your patients, and she's one of our rock stars. All done with her. I think she's all done with her PA program. She did a study internship with Dave Goldberg over in New Jersey. He's a dermatologist, so I'm excited that maybe she'll end up in this field. Do you have any questions while you're on, Alana, for Dr. Rosen? For adults, weekly also, or just kids? Dr. Geronimus is only studying it right now in newborns, but I don't think he'd be opposed to treating adults weekly if the adults wanted to do it. It's up to you. Be interesting to see. But there is a lot of reasons why it's better in a newborn. Merit is on now, so we have all of you people on. Please ask your questions. That's why we're here. I know you're all listening to Dr. Rosen and his answers to these questions. And you can go back if you think you misheard something. We keep these up. We have them from January of 2017. We have over 55 VBF Facebook Lives, one every month. And they're just archived in there, and you can go back if you are interested in seeing Dr. Rosen or any specific person, and go back and listen to them. It gives you a good idea of changes that have happened since 2017. Also, a lot of people ask questions that maybe you forgot to ask, and then you want to ask them, and you'll hear that they ask them. So it's win-win-win. So there's a couple of your patients on here. Where's Sharon Israel? She's always comes on to say hi to you. Where are you, Sharon? But she's not on yet. Her daughter Olivia is off to college now, as you know.
Yeah,
We're-
I saw her not long ago.
Yeah, we're seeing all of our babies now are going off to college, because VBF's been doing this for 29 years. But this whole KT cluster group that you have, all your moms, those girls are all now over 18, right?
Yeah, those make one feel old.
Yeah, well, it makes me feel old. I try not to. We don't talk about that. We're age regressing, right? Again, we're open to any questions. I'm very excited to hear about, some of these new combinations and possibilities where in the past there really wasn't a lot. I do get a lot of questions from people who have ulcerations on their legs with the KT. What do you recommend for those?
It depends on the size and the depth of the ulceration, how chronic they are. They can be very difficult to heal. Often compression helps in that. The vascular surgeon's been treating sort of venous hypertension ulcerations for years with compression. And obviously if you could treat the underlying malformation that's causing the localized venous hypertension and decrease the pressure with embolization or sclerotherapy, that can be helpful. And obviously the topical treatments in terms of actually...
Like wound care?
Wound care, yeah.
Okay.
And most people now have access to wound care centers that are much more sophisticated than they used to be.
We used to have a wound care expert. I think he was here or somewhere in New York. I forgot his name, but he used to answer a lot of our wound care questions, but I haven't seen or heard from him since COVID. I hope he's around.
Well, it's Dr. Antonacci. I don't know if that's who you're referring to.
No.
There's a vascular surgeon on the faculty here that only does wound care, or primarily does wound care
That'd
at
be
this
great
point.
to
So,
get him involved, at least maybe he can
Yeah.
answer some wound care questions for us.
definitely.
Well, we have a lot of you on, so you're being kind of shy and kind of quiet, so go ahead and ask your questions. Dr. Rosen's only here for 20 more minutes. Don't be shy. Oh no, that was another question. That was for Dr. Geronimus. Oh, Stella says hi from Michaela D. Adantni. Adantni.
Yeah.
Stella
Yeah. Hey, Stella.
Odatny. I guess that's how you say it. Hi, Stella. So, ask away, Michaela, if you have any questions. Is that one of
Stella
your...
Darling. Yeah. I think
She's
it's-
one of,
yeah.
that's
Mhm.
cute.
Yeah.
Is that a real name, Stella Darling?
Yeah.
Oh, that's an adorable name.
Yeah.
Sounds like a movie star.
It does.
I think
I've
she'll
always-
be a movie star,
I've always said
Michaela.
that.
Did you?
Yeah.
Or
It's
or an
the best name
author.
in the world. Yeah.
Or an author.
Yeah.
An author or a movie star. Or maybe she'll come up with the new non-currency currency and get rich. Something. Okay, so we can take your questions. We only have 19 minutes left. We've been talking about intervention, embolization. Are there any new embollents? I mean, are you still using Onyx or?
I'm not a huge Onyx fan.
Okay.
Obviously, Onyx and other agents like that, liquid embolics, which could be glue, it could be Onyx. There's some other less common agents that are used mostly overseas. I still prefer the glue to Onyx. The reason being that even though Onyx, technically, you could achieve a cast of the whole nidus of the malformation, often that doesn't succeed, and you're left with a situation where you have very radiodense cast of the lesion, which obscures all your landmarks and makes subsequent treatment more difficult.
Wow.
And there's also issues with surgery after Onyx, and there are people who are strong advocates for it. I'm not. one of them.
I've seen some imaging, and you could see the onyx in the head that was used for AVMs. And
Mhm.
one of the patients, she had it all laid down in her upper gum area, and she lost her teeth
Yeah, it's got a lot
because
of.
it cuts off the blood flow. You
Yeah.
know,
Yeah, it's an interesting thing that sometimes you don't want that complete of a permeation of the lesion.
Yeah, I was going to ask you, is the glue like biodegradable? Like, is it?
No, although it does gradually dissipate if
That's
it's in
what I
place for
wondered.
years. The cast that you see when you first do it, 10 years later, you might barely see a trace of the glue, so that's different.
So you might have to repeat it every 10 years, or?
Well, that would be an overgeneralization, but it doesn't really get reabsorbed. The vessels that you close with glue tend to stay closed.
Okay.
But they just don't retain the opacity the way Onyx does.
Okay, well, that's good then. Sounds like glue does work better. Logically.
Again, there's so many opinions. There's as many opinions as there are people doing these procedures.
So Sharon Israel is saying hi to Dr.
Okay.
Linda and Dr. Rosen. Hi. I was wondering where you were, Sharon, because you're always on when Dr. Rosen's on, and we have Emily is on, and Alana's was on. So your gang is all here, except for a few. I see Demirko, her daughter. What a beautiful young girl she is. She
Mhm.
seems to be doing great.
Yeah.
I see her mom posted pictures, and I'm just like, these girls are just so beautiful. I see them all growing up, and I've seen Julia McGrath. She's now, I think, 18 or 17 or something. She's a teenager, I know that.
Mm-hmm.
And I'm like, how'd that happen? She was just like a baby. So, okay, so we do still have some time, less than 15 minutes, and we'll be signing off. So if you have some questions for Dr. Rosen, anything, we talked in the
One of the
beginning.
issues you raised, and it's probably important to talk about it in terms of the types of embolic agent or sclerosing agents, is the controversy about absolute ethanol. And there are some people that are absolutely devoted to using ethanol in almost every lesion, and some people who are not willing to accept the higher potential risks. It's something that I'm sure is confusing for patients and their families, because there are claims that it's the only agent that could cure, quotes, malformation. And there's no question it's by far the most potent agent in terms of embolization, but it's also not very discriminating in terms of the tissue that you zap with it. So in terms of nerve injury and ulceration and skin sloughing, those are all things you have to be aware of. And there are specialists around the country that have good results, but
At what
the
cost?
downside. Yeah, and again,
Or-
some of them it's been very effective and dramatic, but again, the downside is quite significant as well in terms of complications.
I'll quote Scott, is the juice worth the squeeze? You know, that's right. It's a good, I like how you diplomatically stated that, you know, you do not use absolute.
I mean, I use it on occasion if there's a very well-defined area and you know there's no normal tissues that are going to be affected by
Okay.
it, and you can see where it's going. Yeah. I
But
think
you don't
that's-
just blanketly use it on everybody.
It isn't my primary agent.
Right.
Yeah.
And people should be well aware of it.
I practice in New York, which is not the kind of place where you want to have complications or mistakes. It's an unforgiving environment, shall we say.
Yes, we shall say. Alana Dolce, oh, she came late to the show. Any chance of electrosclerotherapy being used in the USA?
Ultimately, yes. Whether it's 6 months or 2 years from now, I can't say, but it most likely will get approved. And there are people here, including me, kind of peripherally involved with speaking to the company and trying to get them through the hoops. And again, every time there's a new technology, very dramatic claims are made, and I think everything finds its ultimate proper application. So I don't know that it's as miraculous as it's being presented, but it clearly does seem to be a step forward in terms of treatment. So we're anxious to get our hands on it here.
Yeah, have you seen some post-ops and like imaging of them?
Well, we were in Boston, you and I together,
Yeah,
a few months ago, and we saw some
We
pre
saw
and
the
post
ones, yeah.
patients, and some were very, very impressive.
I'll be looking forward to you doing the Germany thing, because you're
Mhm.
going to see it's a completely different way that Dr. Claudia
Yeah,
does it.
well, again, it's new technology, and people
Right.
have different. Some people are giving bleomycin and then doing the electroscleros. Some people are doing it at the same time.
Right, so
Um,
I like what he's doing. He's like, what he's doing is he's using all those little needles to create like channels. Then he puts the bleo in.
Yeah, for people that don't know what this electrosclero is about, it's basically putting fairly high energy electric current through very tiny needles, and it's usually an array of needles, not just one. And the theory is that it increases the permeability of cell membranes in the malformation. When you combine that with bleomycin, which is a more and more commonly used embolic agent or sclerosing agent, that the results are dramatically better. So that's the principle of it. So it's still minimally invasive, but it's using a different kind of energy.
Yeah, and I hope that we have our course, the VBF Italy, for next June. It's going to be the first Friday in June. I'll send you the information so you can plan in Milan. I hope that that's, if not, he's going to arrange so that he can, like, we can televise, like, him actually doing a procedure. But we're going to have something besides, you know, his slides and photos and imaging, because I want people to actually see it. Once you see it, that's it. You know, you'll understand the process. But I'm anxious to hear what's different about Germany versus Italy's. I'm just anxious to hear it. So Naya wants to know, how often did you have in your practice cases of irreversible lung fibrosis after bleomycin sclerotherapy of a venous malformation? Do you think this electrosclerotherapy reduces the risk of this side effect? Do you avoid using bleo because of this side effect? Because in some centers in the world, they avoid to use it because of this.
I've seen 0 cases of pulmonary toxicity from bleo. And one of the important things to be aware of is that the original reports of lung toxicity were over a certain number of milligrams lifetime dose. And when bleomycin was used, as it still is, used as a chemotherapy agent for malignancies, you could reach that and surpass that dose, and that's where people saw pulmonary fibrosis. There are questionably 1 or 2 reports in the world literature using it for malformations and seeing lung issues, but if it happens, it's extremely rare. And as long as you keep track of the lifetime dose, we haven't seen one case of it being an issue.
And that's a really important point, because I know Dr. Coletti's starting this. He's doing a lot of work on when the children start presenting with the lip overgrowth, and we know where it's going, because we
Right.
see these port wines with the port wine overgrowth. And he's doing some, but then he's very cautious, because he has to tell the family there's a lifetime limit.
Right.
And if we divide that, and we started at this age, so he's coming up with his own algorithm of it has to be 15 or 20% enlarged over what it should be, then address it, but a lot of people don't realize there is a lifetime limit on the bleo.
Yeah, and since many of these patients are treated in various centers, probably the patient itself or the family is going to have to pay attention to how much bleo they've had, because it may not be one center that's tracking what the total dosage is over a period of years.
Right, exactly. So Irina, she just jumped on, and she wanted to know if the electrosclerotherapy will be used only for malformations associated with KTS or for all. I guess we'll just, like
No,
port wines and
it's
others.
being used in other kinds
other
of
vascular
malformations.
lesions,
Yeah.
Be interesting. There's a case that I had today, and the infantile hemangioma was literally this big. Completely had the brow, the eye closed, and they want to do, and this is in the UK, so they want to embolize it before they do the resection, because they said it's really pretty high flow. It's got that temporal artery feeding into it. I'm just wondering if this will have some kind of application, even with these massive semi-high flow infantile hemangiomas, that maybe this would be a good to attempt this before resection.
Remains to be seen.
Yeah.
By the way, somebody raised the question of people avoiding bleomycin because of those risks. And the question always comes up, if it works so well, why don't you use it everywhere? And one of the reasons is it's still relatively recently being used, relatively recent meaning 5 or 6 years,
Right.
for malformations. And we tend to reserve it primarily for lesions where you're not going to require a very large single dose, and for sensitive areas around the facial lesions and the hand, places like that, where you want to minimize neurotoxicity, because it's the least neurotoxic of the
What about the perianal area?
any place where you have a very
Yeah.
sensitive vascular bed.
Jonna wants to know, do you give second opinion visits by video chat or telemed or Zoom?
Yeah, I can. I can't say I have an organized way of doing it, but we have lots of people that are sending emails and sending images and videos, and we will converse with them.
Yeah. So you can, his email is posted above, Johanna, and you can write to him, or if you want to write to me, I can work with his people and try to set something up for you, whether it's an actual telemed or a Zoom link or whatever. Just have all your stuff together for when you do have that session.
Yeah, just as an example, what works best in our experience is you send kind of a verbal summary of what the patient's situation is, what treatment's been done before, and a CD, the actual images of scans that have been done.
With clinical
we
images.
frequently initially just get written reports,
Right.
which are kind of useless. You really need to actually see the images.
Right. That's why we love our in-person conference clinics, because you get the people in
Load the
front of
scans,
you.
yeah.
They bring the scan. You've got them. It's great. All right. Well, we are coming down the finish line. There's been a lot on here. I'm really excited that we talked about the electrosclerotherapy, because I think I'm just really excited about it. I really, really feel like this is going to be a game changer for a lot of people. I mean, I'm not saying everybody's going to be cured because of it, but I think it offers a lot of hope. We're seeing now, what we don't know, what Dr. Coletti and I discussed is, he's doing these AVM cases that are extracranial, head and neck. He's a maxillofacial surgeon, and it's dormant, and there's no activity, and he's reconstructing, and I'm like, can it come back? And he's like,
Always. It's always possible.
Yeah,
if you know anything about vascular malformations, declaring something
right.
done, finished is
Right. Ruslan Agababayev, very, very famous pianist with a venous malformation of the lower lip. He's been around. Ruslan, I think we saw you in 20 years ago, yeah, 2003. Yes, hi, Ruslan. You should send me some invites for when you have your classical piano concerts. I'd love to come and hear you. He's in the city. He's in the city here. And he and his family were here, and his sister was just going to medical school. And like I said, he had a big venous malformation of the lower lip. And Ruslan, you really should come to our clinic, our ultrasound clinic in New York for the Vascular Anomalies Conference and have Dr. Coletti do the ultrasound on your lower lip. Because I know you had something done and now it's back. I don't know if you've had anything done again, but there'll be a lot of physicians there, so you can come and it's free, get an opinion. So look at our website at birthmark.org. Would love to see you. If your sister's practicing medicine in the city, bring her along so we can say hi, maybe get her involved in VBF. I'm always looking to recruit new people. So we are finishing up here. It's been very informative, very hopeful for me. Those of you who are doing traditional management of extremity lesions, continue to do that, continue to see your specialist, but know that every day, doctors like Dr. Rosen are exploring new options because they want them as well, right? You want them as well. Oh, Ruslan had the bleo done twice.
Mm-hmm.
I don't know if you ever had a resection or just a bleo. But anyways, come because it's free, Ruslan, okay? And you'll see a lot of doctors there, and and they're all here in New York City, most of them. So come, and Alana's saying thank you. And, yep, thank you, Susan Albert. Oh, that's Emma's mom. Hi, Suzanne. You're welcome. And yes, we'll see you in October. Dr. Rosen for his care of our daughter, of course, and we thank you all. And
anybody has any questions that we didn't cover, or you wanted more details, you could feel free to email. And they're not formal video consultations. We don't
Right.
bill or anything like
No,
that.
no,
We
no.
just give opinions.
right, just informal opinions,
Exactly.
which is what our
Mhm.
conferences are about. But they're very. And again, October 6th, 7th, and 8th in New York City. We'll be doing the talks at NYU. We'll be having a clinic right next door at Dr. Geronimus's office, and Sunday is free laser day. So we already have 70 patients signed up for free laser on Sunday. It's becoming the place to come for free laser. So thank you for your time, and next year when we're back, you should have a lot more to talk about with the electrosclerotherapy. This time next year, we should plan that. We've got FDA approval, and we'll have been to Italy in June, and oh yes, that's Scott just saying thank you. It was great. So anyways, thank you for your time, and remember, you can go back and rewatch this. Take care, be safe, be well.
So on.